Hello students, Namaste and good morning. So the next part of this lecture series of mechanical ventilation, we'll be here first learning about the heart-lung interactions. So let's recapitulate what we did in the previous sessions. So in the first session, we talked about the introduction where we talked about the basic physiology of respiration. So that had included the basic physiology of normal respiration as well as of mechanical ventilation. We also talked about the basic modes of ventilation. We talked about something known as a lung compliance. That was in the first part. Then in the second part, and in the later sessions, we discussed about what are the different kinds of flow, pressure, volume curves over a ventilator that we actually monitor when a patient is on a ventilator. Then in the next part, we discussed about the different kind of a common pressures we use that are known as the peak pressures and the plateau pressures. And of course, we also discussed about the PEEP. So what is their role in the mechanical ventilation? And today we'll be learning about the heart lung interactions. Okay. So when we talk about the heart lung interactions, we'll discuss the what is a normal physiological effect of respiration. As you all know, we have already discussed that a normal respiration which we are doing, that's a negative pressure ventilation. So get back to we'll draw something and then I'll try to make you understand that what does this work. Okay. Okay, so in a normal respiration, what do we see? So we see that we have a normal lung here, yeah. So in a intrathoracic cavity, we just don't only have the lung, we also have something known as a heart. And here you have a right atrium, right? And as well as you have this is here you have a left ventricle. So in a normal respiration, what happens is whenever we try to breathe in the air, so this pressure, this intrathoracic, so due to it's an active process. So this diaphragm goes down, this goes down, and similarly, these are the intercostal muscles which pulls out. So we have a pressure which is negative. This we have already discussed. Okay. So in an intrathoracic pressure, when this decreases, what happens? The air not only just comes in, this pressure, this also pulls the blood this also pulls the blood into the heart. So that is the blood. So in a normal respiration, during inspiration, what do we see? What do we see normally is there is increase in the venous return of the heart. Okay, so there is an increase in the venous return during inspiration. So let's just pick the heart. Okay, so this is a heart and this is a right atrium. So what happens? So let's say the outside pressure is kind of 15 and this pressure is around 0 to 5. So you can say this difference, this pressure is very nice. So this is 15, sorry. Yeah. So this pressure is 15 and this is about 0 to 5. So the blood is very smoothly going in. The blood is following this path. Okay. So now let's say what happens is if we just increase the pressure, so you understand. So in a positive pressure ventilation, so now let's consider a condition of mechanical ventilation. So what happens in a mechanical ventilation? This pressure, now this is not negative, it's a positive pressure. It's a positive pressure. So due to this positive pressure, this also increases. So let's say this increased to 10. And now you see the slope. This slope has decreased, and when this so when this slope decreases, what happens is the blood flow actually decreases. So the blood flow decreases to the right atrium. So this is a major difference between a positive and a negative ventilation. So let's also draw something that's known as a pressure thing. So what happens in that? This is a normal, this is a pressure over time. This is a pressure over time curve. So let's draw. This is a normal ventilation, normal respiration. What happens is a normal respiration. This is a normal thing. Then you inspire. So there is a fall in pressure and it goes back to normal. Okay. Now what happens in a mechanical ventilation? So this blue is, this is normal or physiological. Now what happens in a mechanical? There is no normal thing, and then there is a pressure is increased because you have increased the pressure and it goes down. Okay, and this is a on a ventilator. So this is a difference between a positive pressure ventilation over a negative, and that's the difference which comes into the heart and lung interaction, which is very important. Okay, so we discussed about the normal physiological effects. So we mentioned that there is a normal respiration negative pressure, and it also pulls more blood, and we get a normal during a normal physiological inspiration, we see increase in venous return. So what happens in a mechanical ventilation? We showed that this is a positive pressure ventilation. There is an increase in intrathoracic pressure. There is decrease in venous return. So there is decrease in the preload. So you all know what is a preload and afterload. There is decrease in afterload. This I'll explain. So eventually you get a fall in the blood pressure. Okay, so what happens in the condition of we mentioned that there is decrease in afterload. I'll explain. So what happens is in an intrathoracic cavity, we initially just talked about that we have a heart. So in a heart we have a right atrium and a left ventricle. We talked about the right atrium. What happens that how does actually there is a decrease in pressure, there is increase in pressure at the at the right atrium. So there is increase in venous pressure. So we actually get a decrease in the venous return. But there is also, so whenever there is this kind of there is increase in intrathoracic pressure, there is this pressure which is actually coming from the lung, from outside the lung, which is actually compressing the left ventricle. So what happens is, what does this do? This does is this increases this left ventricular and diastolic pressure, so this goes up. Now what does exactly afterload means? So there is certain pressure at the aorta, and then there is certain pressure at the left ventricle. So the difference between these pressures is basically the afterload. If this difference is more, the patient will have a more afterload, the patient will have a higher blood pressure. But what happens here, this due to this outside pressure, this left ventricular and diastolic pressure, this actually goes up, and now you get something known as this LVEDP becomes like this because of this extra pressure. So now what happens, this actually the afterload is actually decreased. So you what do you see is a decrease in afterload. So when we talked about initially, we mentioned what is exactly a blood pressure. So the systolic is by the resistance by the major conductance vessel, which is the aorta. So if the difference is more, that means more blood will actually pump out. There will be more amount of blood which will go. The higher the difference between pressure between end diastolic pressure and aorta, there will be more amount of blood which will flow out. But what happens if this increases, this pressure difference reduces, this actually you get a decrease in the afterload. So again, that has a very important role in various conditions. This is actually very useful. So let's just recapitulate. All in all, what do we see? We see is decrease in preload, okay, and we see decrease in afterload. So can you tell? You can think where are these conditions actually very useful? Where you actually require this decrease in preload and afterload is very useful. So the first condition which should come in your mind is CHF. So if a patient is on ventilator on a CHF, you actually like these things to happen. This actually improves the morbidity and mortality of the patient. These patients are very useful, but this has a contrary role as well. What you can do is, let's say if a patient is on a shock, the patient is suffering from shock. Now this actually becomes very difficult. So patient is of having shock. Let's say the patient is a shock. So now what happens is, in a shock, you all know there is blood pressure is down, and then you put a patient is on ventilator. So if a patient is put on ventilator, then what happens is, this will actually would reduce the blood pressure, and that may actually worsen the patient's condition. So you need to be very cautious. You need to be very cautious in patients who are having lesser blood pressure. Okay. So we discussed about the positive pressure ventilation, the increase in intrathoracic pressures, decrease in venous return. We also mentioned how it causes decrease in afterload, and eventually we get a fall in blood pressure. We also mentioned about where we should use it, like the condition of CHF, and we also mentioned where we should not use, which is a condition of shock. Okay, so in the last class, the last part we ended that breath stacking has a very life-threatening condition. So we'll just discuss in brief about what exactly happens in a PEEP and a breath stacking. Okay, so exactly we mentioned about the PEEP and the breath stacking in the last class. So you all know what is PEEP. So PEEP is the positive end expiratory pressure. So at the end of expiration, what happens? There is some positive pressure into the lung. So it keeps some positive pressure into the lung. And what does this do? What does this do is this causes is it keeps the alveoli open. So it what does it? It recruits more alveoli. Okay, it recruits more alveoli. So basically what happens is it leads to increase in oxygenation. Okay, so this was the purpose of PEEP. This you all know. Okay. And breath stacking, you already know what that when one breath is stacked over other. So before the patient can actually exhale out all the air, you have actually given one more breath to the patient. Okay, so that's known as a breath stacking. So what happens is because due to PEEP, what happens is there is always some extra pressure. There is always some extra pressure. So this extra pressure will be donated as a positive intrathoracic pressure. And whenever there is a positive intrathoracic pressure, what happens is, again, you all know, there is decrease in blood pressure. So you have to be very, very careful with the decrease in blood pressure. Similarly, when we talk of breath stacking, what happens? Again, the same thing. So in a breath stacking, what happens is, in a breath stacking, so the air has actually not moved out completely. The air is still in the lung, and further more volume of air has come up. So what happens is this pressure starts building inside. So pressure starts building up. So whenever there is a building up of pressure, this will lead to positive intrathoracic pressure. And again, you know, whenever there is higher positive intrathoracic pressure, your blood pressure will down. So you need to be very, very careful. Okay. So this is a problem with the when you increase PEEP too much or whenever there is breath stacking. So actually whenever there is breath stacking, actually patient may die as well. This is so this intrathoracic pressure may improve go so much that this blood pressure can reduce drastically. Okay. So we discussed that PEEP leads to increase in oxygenation and oxygen saturation. We initially discussed. We mentioned about how does it increases intrathoracic pressure and similarly the breath stacking and similarly what happens in the blood pressure. So if a patient is of shock and you want to increase oxygenation, you find that its saturation is going low, so you need to be really careful of increasing the PEEP. So what you would rather do is you will first improve the blood pressure and then only you will try to increase the PEEP, because else patient may actually become more morbid, or there is increased risk of mortality if you just increase the PEEP, if you think more of oxygenation. So now let's get to the last part of this lecture, which is we'll just mention the summary of common mechanical ventilation. So we mentioned about the respiratory rate. So we mentioned that respiratory rate and tidal volume actually are used for decreasing the carbon dioxide levels, and FiO2 and PEEP actually increases the oxygen saturation level. So this you have to keep in mind. So we keep between 12 to 30. Again, 30 is for very specific conditions. We don't even go up to 30. And 12 to 16 is what we normally breathe. So we want it to be more. So again, now the problem is if you increase the respiratory rate, you can actually lead to breath stacking, because now you all know that inspiration is an active process. Inspiration is for lasting about 1 second, and you have around 2 to 2.5 seconds for a normal expiration, and it takes time because it's a passive process. You are not requiring energy out of it. So again, if you increase respiratory rate too much, you can lead to breath stacking, and dead space ventilation is When you ventilate more, what happens is actually there's a lot of dead space of 150 ml, which is the part of the air which is there in the trachea, which is not actually helpful in the gas exchange. So that increases. So that is known as the dead space ventilation. Now, then the tidal volume, we keep it at, now this is where I want to mention 7 to 8 ml per kg of ideal body weight. Please be very sure. Now, what does this ideal body weight means? So, ideal body weight is based on the not the what the patient weight is, but as per the height of the patient. So let's say, let's consider I get a patient who's very lean and thin. So who's let's say he's of 40 kilograms, a full adult of 40 kilograms. So of a height of let's say 5'10". So a 5'10" person with a height with a weight of 40 kilogram, if we go by this, we'll be actually just giving him around 280 mLs of air. 7 fours are 280. So 280 mLs of air will be way too less for that person because our lung parameter is not based on it. Similarly, because our lung size is similar, our lung size is based on the height. So what do you want? Let's say if a person is of 5'10", so you expect that his weight should be something around 70 kg. So what you should be giving is around 70 into 7. That should be 490 or around at least 500 milliliters of tidal volume. Similarly, if I get a person who's way too fat, okay, a very highly obese person. So let's consider his weight is around 150 kilograms. So I won't be giving him around 150 into 8 would be, yeah, 1200 ml. So you would not like to give a person of 1200 ml of tidal volume. Like that's way too much. Your lung doesn't increase. The fat is increased, but your lung size is the same. So again, you have to be very careful when you mention of per kg, but that should be the ideal body weight. Okay. We do not, again, so you don't go beyond that, because when you increase the tidal volume, it can increase the alveolar injury. That we'll be discussing in the next part. How does that happen? So there are certain conditions when there is an acute lung injury, we actually keep it low. FiO2 is the oxygen fraction. So in a normal air, what we are breathing is around something 21% of oxygen. So, and now you know that in a patient who's on a ventilator, we can increase oxygenation. I mentioned that we also give 100% oxygenation when we just intubate the patient, because for a period of time, patient has not actually breath normally, and patient is already sick, so his saturation will actually go down. The patient will actually desaturate. So for that, you do FiO2 to 100% for a few minutes, and then you come back to something around 40 to 50%. If you increase more, then actually it leads to free radical generation. So there is oxygen injury, and whenever there is free radical injury, you all know what does free radical injury does. It's very bad. Okay, so you don't keep it for long. So again, you can't go beyond this. And then, yeah, lastly, you have the PEEP. We have discussed a lot about PEEP in this part. So again, it causes increase in oxygen saturation. We keep something between 5 to 20. 5 is something slightly towards the lower side, and 20 is towards the higher side. But you cannot increase more than that, because then that may lead to fall in blood pressure. This is very high, but then in certain conditions, let's say patient is suffering from CHF, you may actually keep this something around 15 to 20 of PEEP. Okay. So that is all. So I hope you enjoyed the lecture. I hope you understood a lot. And let's see in the future lectures you'll learn. And please be safe. These parts are important. So thank you very much.